I think we should get started here. I'd like to first apologize in case I get the name wrong, but I'm going to welcome Dr. Donal Bisanzio, who's a senior epidemiologist at RTI International, as we just heard, based in England. He's got a degree in veterinary medicine and more than 15 years of experience in global health, focusing on vector-borne and zoonotic diseases, including a focus on improving the effectiveness of control and surveillance systems. So, Dr. Bisanzio, thank you for agreeing to present and welcome, and I'll leave the floor to you.
Thanks so much, Harry. Thanks so much, also Christine, for allowing me to be here today. So let me start by sharing my screen. Okay. Can you see my screen?
Yes.
Let me just okay. Okay, perfect. Thanks so much. So I'm here today to talk about one of my projects. So, and this project was a project about quantifying the effect of immune passport that was adopted by the King of Saudi Arabia in 2021. And the idea was, while I was supporting the country with modeling COVID pandemic, I'm going to talk about this later on. So at some point, one of the requests was about, can we kind of quantify the effect of this immune passport? Did it help or not? And then all the effort to build this passport, asking people to use it, and then also when you roll out this type of passport, you have a big infrastructure around to be sure that everything is working, all the data sets are working, everything is connected. So the idea was okay, can we see if we averted X number of cases, that's hospitalization, so and so. So Harry already said a few words about me, and I don't want to spend too much time, but then just to frame myself here. So I'm a veterinarian, so I veterinary medicine degree. So, and I start with Lyme disease, which is my first law. And many of you, if you have started with some disease, usually that disease remains, in your skin forever, really. And when I was doing working with Lyme disease and so on, I always thought about network analysis. I did a PhD on network analysis. And then at some point, let's say that I start to work on several diseases, and going from Ebola. So I just published a paper on Ebola a few days ago, and you have monkeypox. There is like a model that I created on the monkeypox, and so on and so on. And I spent so much time also in the field collecting ticks, collecting mosquito and so on. And I know that some people here in the call, they're waiting for this moment. And yes, I also collect a sample from squirrels, and I'm the person that estimated the number of squirrels living in Central Park, New York. I know that some people was just waiting for this moment. And and while I was building up my career, so I decided to use models as a tool for, to do epidemiology. So I know that most of people, they think that modeling is the final point, a very important point. And I think that that is the case. But for me, modeling is a way to answer questions that they are a big question on public health, and then also using the insight to help policymakers. And this is what I do in RTI International. So I use statistics modeling to support country in decision. And this is what happened with Saudi Arabia, for example. So just to give you a background about Saudi Arabia and COVID. So Saudi Arabia had the first case in March, but was already doing something before. So when they start to see that there were a lot of cases around the world, they start to do some intervention, they start to close the country and so on, because they didn't want to have a big outbreak. And at the time, we are talking about March, everyone was thinking that closing the border and then doing some kind of non-pharmaceutical intervention, it was enough. But then, you know, the story showed it was a little bit too late for all the countries, almost. So, but then what happened? That since March, as I also a little bit before, so the Saudi Arabia government rapidly introduced no pharmaceutical intervention, like mask wearing, social distancing, lockdown, and so on, just to try to mitigate the spread of the virus. And compared to many other countries, so Saudi Arabia really did everything quickly. And then when you look at the epidemic curve of the country, you see that how they were able to really crash the curve, like you know, happened, for example, in New Zealand and in other countries. They really act quickly, and then they were able to kind of keep at bay the spread of the disease. Then while everything was evolving, so Saudi Arabia also used a lot of mobile applications. So since 2018, the country tried to improve access to health through mobile application. So they have already many mobile applications for the citizen to get in contact with doctor, to have, let's say, visits with a doctor remotely, and so on. And they were lucky because compared to other countries that they have to start everything from scratch, they had already a good system in place. And then the coverage of mobile phone in Saudi Arabia is very high. So, and then when COVID arrived, they diverged many of these applications to support the response to COVID. Like, for example, during the lockdowns, they have an app. It's also the app that I'm going to talk about today. They have an app able to provide, for example, pass to move in the cities. If you were, for example, a particular worker, they need to go to the hospital, and so on. So, and then also all the apps that they were able to track people, and then also provide information, just try to also fight against fake news, and so on. So there were so many apps, and I was really, when I started to work with the country, I'm really surprised about the plethora of mobile application in place. So, for example, I had experience here in UK. As you can understand from my accent, I'm not native English speaker, so I'm from Italy. And yes, there were some apps for example, in Italy and UK, these are from my experience, but I never see I saw many deployed like the one in Saudi Arabia. So, and then what happened that in March 2021, one of these apps, there was like the app to allow people to move during the lockdown, the curfew, was kind of transformed in an immune passport, which means that people to go around to get inside the shops, inside their work, and so on. They had to show this app, and the app has, you know, the possibility to show green symbols, so that the person had the vaccine and they were able to get in. But then it was not all, like it was a recovered person, and so on. So the same kind of system applied in different other countries, like for example in Italy, in France, and so on. So, and this was rolled out very quickly. So we have millions of people apply for the app after March, because without that, people were they were not able to go inside the shops, the malls, and so on. When I was working with the public health authority in Saudi Arabia, so I asked about where, you know, if people that were able to go around outside, maybe meeting outside the shops, and so on, and then they were like, if you were able, for example, on some point to go to your relatives' house, and so on. But most of the time, people they like to meet in malls, and so on. So, and this is why the amount of people using this app climbed quite quickly, so very exponential. And then they start to do also the vaccination. So in December, around December 2020, they start to roll out the vaccination. It was a very, very quick rollout. So they will reach high coverage around August 2021. Just this is just to give you an overview of the country. So in 2000, yes, it was like in the middle of 2020. I think it was like around June. So we got contacted by the World Bank to work together, and in collaboration with the Saudi Arabia Public Health Authority, to estimate the impact of different interventions on COVID-19. So, in the beginning, we start to do just to check the non-pharmaceutical interventions, how that affected the transmission of the disease in the country. So we published a paper about that on BMC Medicine. And then we have different type of scenarios. So our support for the country was really to create a model to test some scenarios, intervention scenarios, like for example, vaccine, the speed of vaccine, rollout, and so on. Like for example, what if we doubled the vaccine speed in adults, with or without a lockdown? Because we are talking about a very long period, was from 2020, 2022, where we really produced many models for Saudi Arabia to support their decision making for the school, for vaccine, and then also for the app, for example. And today I'm going to talk about the part regarding the passport. So as I said before, it was very important. So this was a retroactive kind of retrospective, so kind of analysis. So we were already in the middle of 2022, and we were like just trying to understand the impact of this passport, because the passport was rolled out during the vaccination campaign, and then was meant at the time to keep the transmission, so the circulation of the virus, low while people were getting vaccinated. The idea was like, did that work or not? Because at some point, the idea was like, what if we have different, let's say, variants, and we want to use it again? So just to give you an example, when Omicron started to spread in the country, so they decided to add another vaccination to have the green pass, to have like the ability to get inside the shop. So the booster became a way to have free access to shops and so on. And also because this type of password, being like all digital, they are very easy and fast to update and to change. And what I will say, like every single time I run a model, usually we run for 52 weeks. And this is the flow chart of this project. So there are 4 phases. So the first one was gathering data. And these data are very important because our idea was to create a model able to represent all the population of the country at the individual level, and not just as a big network, but a big spatial related network where every single people living in the right place, and then also capturing the interaction given to the age of the people, where they live, and so on. And we had also to get all these data to the demographics data that they were provided by the census, some remote sensing data, and then of course, so in this first phase where we are getting the data, so a lot of data about COVID epidemiology. During this presentation, you may see something that seems very dated, but you have to think that the COVID epidemiology, so evolves every single, I don't want to say weeks, but even day. So every single day there is something new. And what I'm going to show is what I've done at the time. So if you see something that seems, oh, this is completely wrong, think about when I ran the model at that time, the particular parameter or the particular factor in was supposed to be, the most updated, or the knowledge, information about COVID. So in the second phase, I put together these individual base model. I'm going to talk about this just after this. And then in the third phase, so phase 3, I went to the intervention, simulation. If you may ask why 12 months, when a lot of people, they say that you cannot really model this type of disease for more than 3, 4, or 5 weeks. So the idea is like to have a better kind of like, okay, so we know that we may be wrong, but what if the status quo remain? What if nothing is going to change? So sometimes it's better to give a long time view than just a few weeks, because policymakers, they cannot really just like make decision on weekly by weekly change. And we saw that also during all these in different countries. So it's better sometimes to give like, even if it's like maybe wrong, it's better to give like a long prediction. And again, so for this phase 3, I put also aside all the epidemic data from the Saudi Arabia. Saudi Arabia has this dashboard with all the data like many other countries. And then I had the possibility to have access directly to the dashboard and then take the data. And then at the end, we have the results. And these are for all the scenarios that I run for this project. So at some point, I thought about, okay, so I need to create this model. And what kind of model should I create? So at the time, I was working on a different type of model that was linked with the measles in North Carolina. It was kind of a model that was inspired by the paper written by Patakaran in 2018 in Epidemics, saying that when you want to create an individual-based model and an agent-based model, for me, agent-based model is where your individuals, they have some kind of brain, they move, they decision, and so on. An individual-based model, again, this is for me, this is why I'm talking about individual-based model in this presentation, is where your individuals, they are brainless, they move around and so on, but there is no real decision embedded inside the model. But then in this paper, they will say that when you want to model a disease in a particular part of the globe, there are so many stuff that you have to account for. Like, for example, the age, the demographic of the people, the movement, what happened in their house, in their schools, and so on and so on and so. So that I decided to create a very detailed model. At the beginning, I was thinking to create a model with 10, 20,000 individuals, because that was the classical model that you seen around for infection diseases. And also because, again, so I'm a veterinarian, so R is my second language. I can speak faster in R than in English, I can tell you, and many people, they know about that. But then R is not perfect to do individual-based model. So it's not a very fast language, and then also, for example, Python. And then I was really looking for something that was allowing me to do a big model. I was thinking millions of individuals. Why? We can just start with recreating a synthetic population of Saudi Arabia. Just looking at this paper, I thought like that is something that I should do. And this brought this to the idea to create a framework that I call Cassandra. And the name comes from the Greek mythology, but it was Cassandra, which was, I can say like a witch or something similar like that in Troy. It was cursed to say always the truth, but no one was ever believe her. And I think I thought like a kind of a joke. Usually modelers, they say something and then people, they don't believe them because we are like Cassandra. So this is why I call this framework Cassandra. Cassandra, it's a disease agnostic framework. This was like my idea. let's create something that is agnostic, can be used for different diseases, and can be changed also depending on the scale. I want to model a big city, good. So what if I want to model a country? What if I just want to model an hospital? So, and then it's really like a agnostic for the disease, but also spatial explicit or implicit, depending on the way that you work, but then also the scale, and really doesn't matter. And I'm talking about this after. So, because I want to really account for heterogeneity of human interaction, and then we have a movement and so on. As I told you, I said before, so I did my PhD in vector analysis, vector-borne disease analysis, and then apply network analysis. And then I read so many papers from, for example, Rabasi, Vespignani, and so on. So there was always this idea that heterogeneity matter. And I said, okay, let's put this, let's create a model where heterogeneity matter. And not just the heterogeneity in contact about people, also movement and so on and so on. And then inside, I had to also think about how to implement a compartmental model. So do we have like the classical susceptible, infected, recovered, and exposed, and so on and so on. So I want to really create a kind of system that was like a Swiss Army knife, let's say, something that you can adapt to any disease. So it was very challenging, I can tell you. One of the big challenges I got at the beginning was just like, okay, so what kind of language should I use? Because I'm talking about millions of agents here. And then R, there's no way. So there is no way because the memory, because the speed, I need to have something that was able to run thousands of simulations, because it was like stochastic, in a time the policymaker, let's say in a time window, during which a policymaker will not just say, okay, where is your model? Well, it's like waiting and so on. There should be something fast, something that is to provide an answer in just a couple of days, or let's say at least a week. And then something that can run on a normal computer or on a server. And of course, this will change completely the timing of the results. But then what if someone has not access to a server? Maybe you can wait a little bit longer and they use a normal computer. So I was looking around, and a lot of my friends told me, Donal, you should try C++. I said, okay, perfect. So I know Perl, Ruby, Python, R, Fortran, and so many little languages. And I said, okay, yes, of course, C++ is completely missing my knowledge. And then what happened? So I started to do it. And again, so I'm a veterinarian. I'm not a statistician, really. I'm not a mathematician. And all the stuff that I know, I learned by myself, like, spending weekends and so on, and nights, just banging my head against the computer when my Python code was not working, with Fortran, say, oh, sorry, this is Fortran 2003, not 97, so the code that you're writing is not compatible. I was like, oh, no way. And C++ was not for me. And then I was thinking about something else. And then I was reading, and I found this Julia, which is a new MIT language that it's very, very emerging. Now you can do a lot of stuff. And then what they said, it's like faster, so easier than C++, faster than Python, and maybe also Java. And I was like, okay, I should do that. So, and I try, and I can tell you that Julia, it's very good. And then for people in the call, if you want to try to do very good models that they are big and run fast, Julia should be one of the two that you should try. And just like to make you laugh, so at a certain point, I wrote on Twitter, I don't remember Twitter or somewhere else, but I remember it was like on social media, I love Julia. And everyone started to send me emails and texts, what happened to my wife? Because the name is Elisa. I was like, oh, and then I changed that, Julia, the programming language, sorry. But then the point, like, so I was able to create this Cassandra modeling framework. And I already modeled COVID, for example, for Saudi Arabia. So I was able to have a monkeypox model for Saudi Arabia in less than 7 days. So we just like, when the the spread of monkeypox started, so Saudi Arabia asked me, while you're like working on COVID, can you just like do a monkeypox model? I say yes. And even the monkeypox for Western high-income countries was done with one of my colleagues, Richard Rettiger, in RTI, in really few months. And that was like a very, sorry, a few weeks instead of 2 months. And then I did also Ebola in DRC and so on and so on and so on. So the Cassandra modeling framework is working and is providing very good results. So then I decided to work on that, use that for Saudi. So, and then when you have this framework, which is like it's a module type of framework. So I'm not here to explain every single part of the Cassandra, because I'm like putting together a paper describing Cassandra. But the idea is like you have models inside where you put the information and then you create your synthetic population, and then you have intervention modules here. But then talking about the Saudi Arabia model. So first, I got demographic data, I said before, from the census website. So population per age and sex, and then household size, school size, percentage unemployment, percentage of people that are not Saudi, because we know that there is a big fraction of non-Saudi people in Saudi Arabia, and then also age-specific contact metrics. So that was important because the contact rates among the age, it's very different. And if you don't account for that, you may have a very biased final results. We need to remember that for me, the important part, it was just like creating a model to support the country. So it was not a model just to have a nice publication. I was not even thinking about publication. I was thinking to help the country. So I was trying to create a model in a way that was very close to reality. Okay, even though was a completely, simulated, of course. I'm not going to say that I really recreated the entire country, but then I tried to be sure that the population was dressed as like people in Saudi. So remote sensing, I use WarPop data to have my spatial component of the population, so where they were. So I did like 1 kilometer resolution. So the idea is just to have the people there, so the people, they are together, so, and then they can also move and so on. So then I use Facebook data to the human settlement, because we know that I'm going to show after. So not all the Saudi Arabia is people there. So part is desert. And then also accessibility map. So because I need to calculate the time to go from one point to the other to create the movement of people in my model. And of course, all the epidemiological data linked to COVID in the country, outside the country. So when I had data from the country, I use the data from the country. But for example, for some intervention, so I didn't have like data from the country, so I borrow some information from studies performed in other countries. So the modeling approach was like for creating these IBM to represent the Saudi population. So I have to estimate then the human contact network. So when I got all these people characterized where they live and so on, I start to make them like, interacting with each other. So the population was clustered by settlement. So for every single person, I created a household. Then I have also the schools and so on and so on. And then, as I said before, the epidemic was run for 12 months. So that was like my timing, and the model ran at weekly base to make faster. I didn't do like day by day because there was a lot of wasted time in incubation period and so on. And even the intervention, they were just like introduced, we didn't know exactly when that was like effect, like, okay, you introduced today, but maybe it takes like few days to, to be really adopted. So I was thinking, using the day by day was not my point. So I tried to use, so then I moved to weekly. Now in all my model, I use weekly if the day by day is not required. Then include inside non-pharmacological intervention and also pharmacological intervention. So mask wearing, physical distancing, limited public activities, our Kana app, so the new passport, and then the vaccination campaign. Sorry, there was like an error in the slide. and then to create the social network. So, because I didn't have any data really from Saudi Arabia, I tried to think about like, how should I create this heterogeneity? So, and then first I need to have by age, by sex. So first I had to create, the number of contact per person. That was the most important part. You got like your people in the house, but then you have also all the other people around. So what I've done, I just use the power law. So power law, the classical function, so distribution used to describe the content among people with some changes and so on, of course. But then the baseline was like, okay, so usually a power law is for this type of contact, it's something that's between 2.5 to alpha, between 2.5 and 3. And I applied that to allocate number of contacts among people. And then also this household size, so like 5.6 members per household. And then I really went through a lot of publication about class. So I also created like, school classes and then so and so on. With also, I forgot to put here, but also the health system. So it was like really a way to quantify the importance of quantify the interaction among people. And then at the time, people have also said that you were not able to get COVID if you were like less than 15 minutes in contact with someone. So I put also that inside the model. So you have also the amount of time that people spend together, again, following a power law. There was like not, of course, created for Saudi Arabia, but then, for other setting and so on. So I decided, okay, to borrow this kind of parameters. And then I include Saudi, Saudi builder worker, living dormitories and camps. That is like what is there. And then accounting also for migration using a gravity model. They account for people, accounted for the distance, but also accounted for the timing to reach places around using the friction map from the Malaria Atlas project. So what I've done using the world pop data, so I created kind of areas. So say that they were like 20 kilometers by 20 kilometers. They were like my kind of core location, my like in quotes, I can say settlement, where people that were like interacting and then they were moving from one square to the other. Before I tried to use something that was like smaller, but I got very similar results, but then with computing time too big. And then you can see here, not all the Saudi Arabia people there. And you need to account for that because people, they need to travel a lot, for example, to go from the north to the south, and then so on. So, and then there are some places like Riyadh, the Mecca, and Medina, where you can have people there. And then also I did some modeling, for example, for Hajj, which is like the pilgrimage in Saudi Arabia. So I really need to have some kind of special component in my model. So for the transmission, so at the time I put like delta, but also the previous variance. And again, so maybe all these is completely outdated, but at the time was what people they were thinking about that. And then also the data on hospitalization and that they were calculated using the data in the dashboard of Saudi Arabia. So then what I've done, every single time I did my model, I calibrated the model to recreate the curve of the epidemic, and then I change some variables in the model to create new scenarios for vaccination and pharmacological interventions. So the mask wearing in Saudi Arabia was very high, social distancing in it, and also a lot of people that they were infected, they were doing fully isolation. So those parameters, they were from scientific, from scientific literature, but also from the public health authorities. So we had calls every week with the World Bank, with the team of the World Bank, and also I think it was like every 2 or 3 weeks, a call directly with people at the public health public health authority. So my point was I want to do something that they were able to kind of think that they were, co-leading, because this was the most important part. So I was not just a work that I was doing by myself and that's it. So everything was meant to be used by the public health authorities. And this is why I didn't use any models that were like very formula driven. This is more really a model, was like a rule model. We have a many rules in the model. And then for me, it was very, very simple to explain to non-modelers, or people that they never model anything, or they were like completely naive to individual-based model. Then also we have like, because we took like, in case school were opening, with mask wearing and social distancing, as they were thinking to do at the time. And then, of course, the immune passport that they started in March 2021. So the time for the app model, so we are talking about still like at the beginning of the vaccination campaign, still like a fair amount of people, they got their first dose, and then some people already the second dose. So I still estimated during that period the number of vaccination per day, and then the lag between two doses. And the vaccination, of course, was for people that were above 70 years they were like above 70 years age, and with a maximum coverage of 95%. Because I didn't know at the time how big will become this coverage. So I say like you always have like a fraction of the population that they're not going to be vaccinated for different reason, health reason, belief reason, and so on and so on. So I'm going to go straight to the results. And for the results, so again, so this is only to check the effect of the immunity passport. So on your left, you have what happened in reality, and then on B, what happened if the passport, let's say they decide not to roll out the passport. So looking at these, so what I was able to say to the public health authorities is just like that using the passport, the immune passport, so it was very good because they were able to keep the transmission, the circulation of the virus low. So they were able to vaccinate enough people. And then at a certain point, when the vaccination coverage was very high, so that is when you start to see a completely rapid decline of cases. And then, for example, so here we have the numbers with and without the app. And then, so the difference, like 1.3 million of averted cases with 100,000 averted hospitalization and 270,000-ish deaths averted. And of course, one of the big limitations of these is that maybe the app also trigger the run to get the vaccine. So maybe without that, vaccination rollout would be like slower and so, but there is no way really to account for that because it was so difficult. But then the idea is like it's roughly what we thought happened. Something that also they ask, say, okay, when the vaccination was the coverage was very high, so we are talking about August, there were already like a very huge amount. I think it was like 80% of the population above 17 already vaccinated. So schools, they're still closed. You have, still the kids that they don't go to school and so on. So the idea was like, did the app work during this period when, after you reach an important coverage, or like a high level of coverage, is the app still working or not? Because maybe you don't need that anymore. Now people that are fully vaccinated and so on. And then we just like decide to check what happened when you really have this type of, you really have like the vaccination at high level. So we saw that still you have the effect of the app. So these immune passports still work when you still have some part of the population that they cannot be vaccinated. And then you can see here that, yes, so even that particular part, which was from August to November 2021. So there was still like some averted cases that we may link to the app. So in conclusion, so I want to say that these modeling exercise show that the Tawarkana app really had an impact on the transmission of SARS-CoV because it was able to keep the transmission low while the vaccination was reaching high coverage. So we have like 1.3 million cases maybe were like averted by applying these app, and then that app may save like roughly around 27,000 lives since March 2021 when the app was deployed, and then can be also important in the future if we don't know what's going to happen with SARS-CoV-2. So maybe there will be new variants, and then we can invite the vaccine, and then maybe we need still like to buy some time to get like a new vaccine and so on. But also we have to think that this kind of immune passport, they're like new because we know about the the one for yellow fever, for example, but then can also be applied again as an app in case there is a new kind of health emergency, emerging disease, re-emerging disease, and what about novel disease? It's something that may be used to still like buy time for the health system, because this is what really this app did. So both time for the health system to cope with the outbreak, because it was able to keep the hospital not completely full of cases, but then allowing also to reduce the transmission around, and it was very important. Maybe something that we can think also for to have for future outbreaks. And this is what I have. Thanks so much.
Great, thank you. Nice talk. We have time for some questions if anybody's got any questions for Dr. Bisanzio. I will throw out a couple just to get things started. Folks, please do put things in the chat, or we have a Q&A right here. Here you go.
We do, yeah.
Okay.
So here's one of the slides. Transmission probably per hour was about 0.07. Can you speak more about how you got to that number, and if you can convert it to transmission probability per encounter?
Yes, so that is good. So I read all the transmission dynamic, all the transmission events that they were published at the time, and there were many about people staying in restaurant. They were quantifying how long people they stay in the restaurant with someone that was infected, or in the house, or maybe the chorus. Remember this kind of big paper about people, they were in a chorus and so on and so on. And then what I've done, I back calculated for all these, so the amount of time that they stay together, and then calculated how many the amount of people that they got infected. So in that way, I calculated the per hour, probability. Still very rough, but then at the end, I found out that was kind of good enough, because then, of course, it comes from real data. It's not something that I made it up. And then when Delta arrived, so we are talking about for Delta, we didn't know too much about it. So a lot of people say that Delta was twice more effective than the previous one. And I know that some people that will scream at me about this, but then I just multiplied that by 2, really. So when you don't have enough data, we know with COVID at the time there was so many information, good, not good. I did a model when Omicron arrived, say that all the vaccines that were not good, and then when I ran the model, I was shocked by the effect of by the size of the epidemic with the Omicron. But then we discovered that still the vaccine was still working for Omicron. But I always try to use the most updated information at the time.
Okay, so another question here. Did your model include any parameter estimation, excuse me?
No. So I didn't do that. So the model at the parameter from the beginning. So I didn't do any model parameterization to the inside the model to get directly the let's say the curve to fit the curve like. So what I've done is really like arbitrary. I changed some of the parameters, again linked to the scientific literature, and then when I used those parameters, so I didn't do any kind of randomization, so I like some kind of parameters that I put in, and then those helped me to find the right model that was able to describe the real curve of the epidemic. So I didn't do anything like the classical stochastic approach to find all the parameters, because I was not very keen to that, because sometimes you can have one parameter that can get crazy in this kind of fitting, and maybe you won't find any publication that said, oh, that parameter it's in that range. So now I just try to find some ranges through publication and I use them.
Okay, great. I don't see any questions at the moment, so I'll come back to the question I've been interested in hearing you discuss. So the vaccine passport is sort of, I think, based on the notion that a vaccination confers a high confidence in immunity. Now, as we've seen with the vaccines, even with here in the US, the newest bivalent vaccine, that there is definitely a waning. You're not immune once you've got the vaccine, although it does reduce risk. So did you incorporate anything in the model that would account for either the efficacy of the vaccine or of the waning of the efficacy over time?
Yes. So first, we have to remember that Delta came here inside this system in August 2021.
Right.
Okay. So just like, so the point is, and then also for the time. So I put like waning inside, but still like the time of the vaccine. So it was just like that was at the beginning. So when it was not already, in theory, we still have like 6 months, of which they almost covered by the first variants of COVID. I put that in, but I can tell you that with waning or no waning, because not the presence of Delta for a long time, and then there was no Omicron at the time. So for this model, so really didn't have any big impact. In model that I did for Omicron, and so yes, I put that inside. So there was like a waning based on the most updated publication. So I can tell you that almost every day I check my parameters in the model to be sure that they are linked, to the most updated results. Yeah. I don't know if this answers your question.
Yeah. So no, the other question that I'll follow up on is to say, it was really interesting that you're doing a longer time horizon than many people will tackle, as you mentioned. And as folks may be aware, one of the efforts that we're involved in is the MIDAS Coordination Center, is the Scenario Modeling Hub. We are looking at exactly that kind of question of what can be done to stretch time horizons to 6 months, or in some cases even a year. So I'm curious, in that, you're doing only retrospective data here, but would love to hear your thoughts on, say, prospectively going forward and doing something like this and looking at the possibility of what happens if another variant comes up and how does that impact longer term progressions. Have you given any thought to what that might look like in your context?
Oh yeah, so you may laugh, but I model phi, which will be like a new variant, let's say. I was like looking for, and then so I modeled that because at some point for Saudi Arabia we said that like, what if there is a new one, and say okay, let's do one that is completely avoid any vaccination, or like you cannot find, for example, with one of the studies they say about Omicron, that maybe the rapid test was not working. Some people got Omicron and then test was negative. So I use that. And then for the prediction, so you may be shocked what I'm going to say. So in November 2020, I predict August 2021. Let me think about, yes, yeah. So, sorry, in November 2020, I predict November 2021. And so my results, they were, yes, so my results were very similar. So I say, this is published, it's published on BMC Medicine. I say, okay, so Saudi Arabia should have this amount of cases, 350,000, and this amount of deaths, 6,000. And it was like kind of spot on. And I can tell you why. So I was spot on because A, the country intervention, they didn't change too much. People, they follow the rules and so on. And we can talk for hours about that. But then compared to different countries where every single day you got like something new, again, so I live in UK, I can tell you that nothing stayed like fixed for so, it was like lockdown in, lockdown out, school in, and then school out, and so on. And then, of course, for a model, it would be an headache. But for me in Saudi Arabia, I was like an heaven because everything was like, okay, we have lockdown, we have these, we have how, you know, closed these and that. And for me, that made my job very easy. So I was really able to predict, you know, a long time because the system was not perturbed by human behavior. And then at the time, again, so Delta arrived in August. Until August, I was fine. Really, I can tell you, like there was like, and then every single time I changed something, like, okay, so for example, in around February, they say we are going to change a little bit the lockdowns, and so we are going to open this and that. For me, okay, perfect. I'm going to do that in the model, and the model is going to recreate that or not. But then again, answering your question, if you want to do long time prediction, it depends the type of country that you are going to predict. So we are talking about a country in which people, they follow the rules. They were like, really, like they made in a way that you need to follow the rules and so on. So it was like very linear. They didn't go back on what they said and so on. The passport started in March. That's it. Everyone has a passport. You have people at the shops checking the passport. You have it, not in, you don't have it, you don't get in. That's it. So and so and so. So I travel in Italy, and I can tell you that I will never predict anything for more than 6 weeks in Italy, in UK, in US, in France, in Germany, and so on, because it was like every single day was different. I remember I was like reading a newspaper from Italy, and then today we are going to do this, and tomorrow you don't do that, and then this particular region decide to do. And then in the UK was the same. So some people decided, you know, they were to follow the rules. And at some point they say, people, they have their own. So if they want to wear a mask, their own decision. How can you model that, right?
Yeah, I mean, that would be another interesting question, of course, to look at what it would mean to have less than 100% adherence to a passport.
Exactly.
And you could imagine a situation where people might use that in public spaces where it was easily enforced, but less so in other state spaces where enforcement wasn't quite so active, and that would complicate the modeling. And my gut feeling says that the impact could be significantly reduced pretty quickly.
Oh yeah, I can tell you, when I was I was in Italy, and my town is 800 people. We know each other. We know everyone. Right. So, and I can tell you that I was able to go around, get in with my immune passport from UK, and people say, "Oh, just come here." And at some point, I got like very, very upset because as an epidemiologist, I told one of my friends in a bar, "You know me, and because you know me, that doesn't mean that I'm like protected from COVID. How do you know that I'm not an asymptomatic one?"
Yes.
And he was, "I know you, but you don't know my status, like is infected or not." And he was laughing, but then I was thinking, if a lot of people, they do this, even in UK was like that. I don't know other countries because I don't have experience, but even in UK, so you see like people getting in shops, they know people in the shop that are taking the mask out.
Right.
Off. Why you do that? Like, just because we know each other? No, keep it on, please. Thanks.
Yeah.
Indeed. But you are completely right. Yeah.
Okay. Any last questions for our speaker? All right, well, not hearing anything, it's about the top of the hour, so I think it's a good time to wrap it up. I want to thank Donal Bisanzio for an interesting talk about vaccine passports in Saudi Arabia, and thank everybody for attending. Have a great holiday season and a happy new year, and we'll see you all back in January.
Thanks so much again. Thanks a
Thank
lot.
you. Take care.
Thanks. Bye.
Bye. Happy holidays.